Thank you so much, Co-Chairs Miller and DeLauro and Madam Speaker, for the opportunity to address the House Steering and Policy Committee on the urgent need for health care reform. To succeed, reform must be built on three strong pillars: personal responsibility, shared responsibility, and shared risk. And thankfully, these are the three pillars of H.R. 3200. Shared and personal responsibility mean employers and individuals should be expected to contribute to the cost of their coverage. Yet this responsibility creates a countervailing obligation on the part of the government to ensure that workers and firms have a good, affordable insurance choices that offer security and stability. The third pillar of reform, shared risk, requires a new national insurance exchange that allows workers without secure coverage to join good group health plans with premium assistance to ensure affordability for middle class as well as lower income Americans. And crucially, shared risk means that this exchange must include a choice of a public health insurance plan competing on a level playing field with private health insurers. Indeed, the public health insurance plan is a linchpin of this distinctively American response. It will provide a stable backup for people without workplace insurance, a high benchmark for private plans, and a cost-controlled backstop for enrollees in the nation as a whole. In most of the country, a small number of large health plans are the only real choice. Lacking effective competition and facing consolidated provider groups, private plans are passing on costs to enrollees and employers rather than improving their own efficiency. Now, new rules for private insurance, such as the fine ones contained in H.R. 3200, will go some way toward encouraging plans to focus on value. But without a public plan as a backup and benchmark, insurers will still have ways to maximize their profits at the expense of health security, driving up premiums and out-of-pocket costs. A competing public plan is a backstop to ensure that this will not happen. Public insurance has lower administrative costs than private plans, it obtains larger volume discounts, it does not have to earn profits, and the experience of Medicare suggests it has a superior ability to control spending while maintaining broad access over time. But for the public plan to work, it must have the ability to set up an extensive network of providers immediately. Providers who accept Medicare patients should be assumed to participate under the new plan with the right to opt out, rather than being required to opt in. And since participation in the public plan will be voluntary for providers, the plan should be able to establish rates based on Medicare rates, much like many private insurers do today. Requiring the Secretary of Health and Human Services to figure out new prices from scratch in consultation with providers is inefficient and gives private plans, which already have networks in place, an unfair advantage over the public plan. It also reduces the federal budgetary benefits of the public plan, as the Congressional Budget Office has strongly signaled. Now, some have said that we should wait to see if private health insurance turns itself around before we create a public plan. This would be a grave mistake. Any reasonable trigger based on the failure of private insurance to provide affordable comprehensive coverage should have been pulled a long time ago. Triggers have not worked in the past. Remember the Medicare Part D trigger, and a trigger has no chance of working unless it's based on a single national standard and prompts the immediate creation of a national public plan, rather than the introduction of a public plan on a decentralized market-by-market basis. For most who support it, a trigger is just another way of saying no to public plan choice. And the same is true of another putative alternative, regional private health care cooperatives. Cooperatives, much like the nonprofit health plans that exist today, are not a serious means of reliably achieving any of the public plan's critical goals. They would not be available on the same terms nationwide. They would not have the reach or authority to drive broadly implemented delivery and payment reforms or to act as strong public-spirited competitors to private insurers. Indeed, they would face the same problems breaking into markets that other private plan competitors face today. Make no mistake, Americans want to have the choice of enrolling in a public health insurance plan. Even after weeks of lies and misleading attacks, strong majorities continue to want a choice between private insurance and a public plan. And according to a survey just out in the New England Journal of Medicine, a strong majority of their physicians support public plan choice as well. Patients and doctors appear to recognize that such competition is the key to creating greater choice and accountability in increasingly consolidated insurance markets. It is certainly the key to balancing personal responsibility, shared responsibility, and shared risk, the three pillars of a distinctively American solution to our nation's healthcare crisis. Yes, we should not let the perfect be the enemy of the good, but let us not also let the expedient be the ally of the terrible. Thank you.
Thank you very much.